The views and opinions expressed in the following program are those of the participants and do not necessarily reflect those of KSMQ Public Service Media Incorporated or its assigns.
Electronic medical records have been a hot topic throughout healthcare in the United States for the past several years. President Obama's meaningful use stimulus dollars have added even more fuel to these fires. Today, we are joined by a healthcare expert to talk about how electronic medical records are used in healthcare today. I'm Sean Riley, and you're watching Health Connections. Today we're talking about electronic medical records, or EMRs for short. Joining me from Owatonna, Minnesota is our guest, Dr. Carrie Bunkers. Dr. Bunkers is a family practice physician and is the physician leader for the Mail Health System's EMR implementation. Carrie is employed by Owatonna Clinic, a member of the Mail Health System. Dr. Bunkers, welcome to Health Connections.
Thank you, Sean. Pleasure to be here.
So, Dr. Bunkers, most people think of an EMR simply as putting a computer in every exam room. What really is it?
It's actually really a lot more than that. It's a whole different way for the physician to interact with all of the knowledge that has been gained and gathered on that patient. It's really taking what used to be a brown chart or a paper record and putting it into a format that is accessible to anyone on the healthcare team that might need it without having to actually physically move that record around. So it's the availability of that data to have it be where it needs to be, but it also has a lot of other key components that play into it. It has the ability to interact with other systems such as the public health department and things like that. It has the ability to bring in things from the internet or other sources of, we call it best practice, but so if a physician is sitting with the patient, they have the ability to have what is current state-of-the-art best practice right at their fingertips in the exam room to know exactly what's the latest drug to give a patient for a particular condition. So really a lot of quality and safety items built into it.
Well, so with all these quality and safety items, are the advantages completely for the healthcare person, or is it more for the patient, or a little of both? And what are the advantages beyond simply saving trees with the paper records?
I think the advantages optimally are for the patient. I think there are some advantages for the healthcare system that employs the EMR. The advantages for the patient are that their data that they need for their physicians and their healthcare team to treat them is available to them at that time. So if, for example, I get treated in Austin and then I get moved to Rochester, the providers in Rochester have access to the tests that I had done in Austin, and I don't need to have those repeated. So that's a key component. There are also some other ways that quality plays into it, but maybe I'll leave it at that.
Okay. So with these impacts, so it's definitely beneficial for the provider, for the healthcare provider. It's definitely beneficial for your patient. And as you're walking through that, is there anything that you would say an EMR is not wonderful for right now? What's the downside?
I would say that many providers would say that it's not beneficial for them right now.
Okay.
It's a huge change in the way that physicians do their job, and they've had a lot of time to become accustomed to the way that they interact with a brown chart and the patient, and get used to that process, and having the available data there and having to change their processes is not always an easy thing.
So is it a matter of culture?
Somewhat a matter of culture.
Okay. So really, it sounds like you've kind of got the double-edged sword here. You've got the, yes, it's a benefit because they can get to information faster. They can get to information that maybe they couldn't have before, where you just mentioned if I'm in Austin and I need to be seen in Rochester, I can move that information. But what exactly beyond simply getting used to it is the downside there? I mean, when you say physicians don't necessarily see it as a good thing, what beyond simply getting used to a new practice is there?
I think many physicians are afraid that it will detract from their relationship with their patient.
Okay.
And I've certainly been in situations where I'm giving my story to a physician and he's busy typing on the computer, and it doesn't really engender my relationship to feel close to him and like he's really paying attention to me. So I think there's that worry. I forgot the rest of the question.
Well, so what I'm hearing is the physicians would rather be talking to a patient than a computer, basically.
Yeah.
Yeah. So what do you see as kind of the next step is there a next step that will get beyond that?
I think the other reason that perhaps physicians and other users of an EMR might get frustrated at this point in the development of EMRs is because they are not as far advanced as some other forms of technology, such as our airline industry. I mean, the ability to make a reservation and figure out the complexity of an airline schedule and have that be so automated, or the banking industry. You know, they're 10 years ahead of us, and providers expect the EMR, with all of its complexity and security measures built in, to be as easy to use as Google, and we hear that a lot. I just want it to act like Google, and we need to remind them that there is a significant amount of complexity that goes into it that prevents it from being like Google, but also the vendors really do need to, again, move things along and put more money into the research, and they are doing that to make it more user-friendly for the providers.
So why do you think it is that healthcare is behind the curve when it comes to technology? Because healthcare has a huge amount of money given to it. It's 16% of the GDP of the entire country. Gets huge dollars, granted for all sorts of things, not just technology. We've got incredibly advanced sites like Cleveland Clinic and Mayo Clinic and Intermountain Health, and sites have been able to do amazing things. Why do you think that an application that's for these physicians, or should I say, why do you think the healthcare tool set is that far behind in industry like automotive or airline or such?
I think the incentive to move it along hasn't been there. With the government payers and reimbursement and the complexity of our insurance industry and the other demands that are placed on the healthcare system, I think that's part of it. And I think again the complexity of it, when you add the security layers and the HIPAA layers and the complexity of the medical data, it makes it more challenging. There's a reason that Google and Microsoft aren't really in the EMR business, I think.
Yet. So one of our people from Twitter actually has kind of come back with somewhat of a response in this, and says, and I'd like you to react to this actually. The comment is that performance improvement or improvement within healthcare, quality improvement, right, is very different than other industries because physicians aren't as linear. They're more of an artist than they are, say, a scientist. We watch shows everywhere. We watch House, and we watch stuff on ABC that my wife loves that I can't remember right now. But you watch these TV shows, and you see doctors move in this very linear fashion. But I think the reality is that if you've got 5 patients and one doctor, and all 5 patients have the exact same disease, the doctor may treat all 5 differently, and it may be perfectly appropriate to treat them all differently. And that's kind of what this person from Twitter is coming back with, is that doctors are artists and not scientists in the same sense, or not linear in their thinking, and maybe that's part of healthcare's issues. Any reaction to that at all?
I guess I would agree, and that sort of plays into the complexity of it too, because those 5 patients are certainly not the same. They have different social situations, different insurance situations. They have other coexisting medical conditions, and so there's a lot that goes into determining how you treat that patient. I think, and there are a lot of things that providers today are measured on, and they're measured on the quality of care that they receive, that they give to patients based on how well are their diabetic patients controlled by certain measures and other quality measures. They're measured by how satisfied their patients are. They're measured by how much money they produce for their health system, and they're measured by their, the employees that work for them. How satisfied are they? So there are a lot of conflicting issues when you look at being a provider and how you deliver that care. So what might be the best thing for a patient in terms of quality and diabetic care might really make them mad. So you have to balance the patient satisfaction with the quality and also their ability to pay for it.
Yeah, what do you mean I have to lose weight? I like this insulation. It's winter. It's cold. So as you kind of look at that too, so one of the things we haven't touched on at all is the regulation aspect of this. Now, when it comes to the maturity of the healthcare industry's technology overall in the EMR, do you think that the regulation that's been split between state after state after state, do you think that's also kind of played into some of the difficulty of this industry maturing technologically?
Absolutely. Some of the requirements for the stimulus dollars include the ability to exchange information with outside entities, but some of those outside entities don't exist yet, and if they are state by state, and your healthcare system, like Mayo Health System, encompasses 3 different states, which ones are we required to provide information to? And there's different rules with the way states reimburse versus the way the federal government reimburses and private payers. So a lot of complexity.
Okay. So with that complexity and actually going to the stimulus package that you were talking about, President Obama was able to pass, as part of the national stimulus bill in January of 2008, a component of $19.2 billion for healthcare. Now, we know that different sites throughout the country, one of the most expensive ones that has been a single institution putting in an EMR, cost them almost $4 billion for themselves, one institution. Do you think that $19 billion is enough to really spur technological growth, or is it just a drop in the bucket and just to kind of start people feeling itchy and moving? So
I think it's probably a drop in the bucket. It's not free money for systems. We are currently trying to estimate how much money it's going to cost, just as other hospitals and health systems across the U.S. are. How much really is it going to cost us to, put in place what we need to receive those stimulus dollars back? And many people are quoting numbers that somewhere probably about half to 3/4, depending on if your hospital or health system has the hardware already or the software or what exactly you need to do. So there's a lot of work that needs to go into it, and I think that's the impetus to maybe get people started thinking about it, but it certainly is not enough to sustain it. We have, I believe, somewhere around 6% of hospitals nationwide are up on some form of an electronic medical record. That's an awful lot that are not, that need to be looking at this. And those stimulus dollars, in addition to the incentives, there start being penalties in 2015. So not only will you not make money, you will start getting penalized. So that scares a lot of healthcare systems as well.
So, as you said, 6% of the medical facilities across the country have an EMR today. Since it's such a small segment of the marketplace, do you think these technologies will get cheaper as time goes on? I mean, one, we expect to see a maturity, but would you expect the costs to really come down for implementing these technologies?
My guess is no.
Okay.
I think that as you add more complexity to them, the needs will continue to grow, and vendors will find ways to continue to charge for their services. So that would not be my prediction that they'll come down in price.
Okay. So how about the other side of it? One of the big assertions that's been made is that the reason that the national reform and for the stimulus package and all is to push towards EMRs. One of the big assertions is that electronic medical records will bring down the costs of healthcare overall. We know, and you don't believe that the EMR cost will come down, but do you think that an EMR can bring down the actual cost of care?
I do. I think it when it is fully implemented, which has several steps to getting there,
Sure.
It will add significant efficiencies to the system to help us avoid duplication of tests and other things that now really significantly contribute to the cost of health care. And in addition, it really is the key to allowing us to manage chronic diseases, and I think that's where the future of medicine is going. It's not going to be, like it has for the last 50 years, an acute care-based visit system where I get sick, I go to the doctor, they treat me, and I go home. It's going to be more of a global management of that patient and that patient's chronic medical conditions like diabetes to try and prevent them from utilizing, the healthcare dollars and having to go to the hospital and et cetera.
Okay. So do you see the EMRs maybe becoming a niche market then, so that it's diabetes and heart disease and those type of things, or do you still think that it'd be more of a covering for a person's entire healthcare background, their entire past history, medical history?
I see it as ideally incorporating all of the person, because they certainly aren't just their diabetes or their hypertension, and treating their diabetes involves many different aspects of the healthcare team, not just one part. So I think that it's all-encompassing and important that it stays that way. I don't know if that answers your question.
Sure. No, as we have talked about cost factors, now the cost impact is certainly what, on a national basis, what the politicians are very worried about. They're worried about how much is this costing the country. But from the healthcare standpoint, usually what I hear from people is that they're talking about safety, quality, efficiency, and those are really the big keys with the EMRs. What are your reactions there? Do you think cost is really the driver for an EMR, or do you think safety, quality, and the efficiency is something we might touch a little differently on? But go ahead.
I remind providers on a daily basis that the reason that Mayo Health System chose to implement an electronic medical record across our health system was to deliver quality care to our patients, to better be able to implement quality and safety measures into the standard care that we deliver. We certainly hope that efficiencies will be a byproduct of it eventually, but efficiencies are not, and it might be system efficiency, but at least on the short term, it's not provider efficiency, and that's frustrating to providers.
Sure.
In terms of cost, I think eventually it will be a cost savings, but it will take systems years to recoup the cost of implementing the EMR.
Okay. So when you say provider efficiencies, not so much. System efficiencies, probably. When you're talking about system efficiencies, could you speak to some of that, of what type of things? If we're not giving efficiencies to providers, then we're going to assume that accessibility to care is not necessarily getting better. But if we're streamlining the back end of the system, what's not seen directly by the patient, what are some of the advantages there, and what are some of the things you could see streamlined?
A couple examples. E-prescribing, for example. A patient can request their medication be refilled instead of leaving a a message by the on the phone, and then that goes to my nurse, and then that nurse finds my chart, the patient's chart, and then she puts that on my desk, and then I read the note and I look through the chart, and then I say, yep, okay to refill this, and then I send it back to my nurse, and then she calls the pharmacy, and then the pharmacy several hours later, fills that prescription. It's not a quick, efficient process, and I think the ability to have the patient, email in through a patient portal, can I request that my medication be refilled? It goes right to my EMR inbox, so to speak. I see that. I have the ability to look at their record right there. I shoot it back to the pharmacy. Yep, refilled. So it's saved a lot of people's time and the cost to pay those people for that. So that's one example of system efficiency. Another might be notifying patients of results. Again, same thing with those pieces of paper sitting on the desk and waiting for me to write a note on them to give it to my nurse for my nurse to call them, or to send a letter. I have the ability to look at it online and send off a record or a mail, or tell my nurse, send an email to my nurse to notify the patient right then, and it saves a lot of steps. So a lot of system efficiencies built in that way.
Okay. And when you mention e-prescribing, one of the things that, again, this has kind of hit the blogs and that side of the world, kind of yet to be seen, but it sounds like e-prescribing is going to make insurance companies a lot more efficient too, where it should allow for people or patients when they go in to have their formulary, their drug formulary, all done for them automatically, instead of this process of, let's call the pharmacist and say, here's my drug, and then it's come back with, well, but that drug's not on your list, you can't have that one, and back and forth. Is that, do you see that also being true?
Absolutely.
Okay.
That is a requirement of bringing up e-prescribing, is that the patient's formulary be checked, and part of that process, so I'm not allowed to, or at least I'm warned if I try and prescribe a medication that is not on their formulary. So I think that aspect will please patients.
Okay. Okay. So as the EMR evolves, what do you see as some of the next steps? Do you think, we've heard about health information exchanges, and as you said, they're part of the meaningful use guidelines, but most states don't have them yet. We know that states in general are hoping to be able to try and take information, not on the individual, but on kind of a high-level information, bring that together for, say, diabetes research, or for research about chronic disease management or such, and quality indicators on large population-based systems. How do you see an EMR evolving? What's next? Where are we going from here?
I think we'll see a lot more of that communication between both the patient and the EMR, and the EMR with other EMRs, hopefully, and other systems, so to speak, pharmacies, et cetera. I think that one of the really neat areas is going to be the communication with the patient. So I see in the future the goal being that that patient really owns their medical record. They have a personal health record, and they allow or give access to whom they want to give access to. And so when they go from place to place, down south for the winter, they're able to give that access, and that provider has access to anything that they would need.
Okay. Well, the concept that's the terminology that's being thrown around by places like Mayo Clinic and Microsoft and such is connected care. And do you see that concept of this patient-centered medical home / connected care that, as you said, evolves into owning your own personal health record? Do you see that being a great advantage for the patients moving forward, or is that something that I just have to do it like my taxes? I have to do my taxes, and oh yeah, I got to update my own health record. Or do you see it as being something that really gives the patient an advantage?
I'm sure patients get sick of answering, so, why are you in today? There's probably 4 people that asked them that same question.
Yeah.
If they were able to answer that once and that information was available to everyone, I would think it would be beneficial to them. Same with your medications. You know, if they were able to go in the night before their visit and update their medications and not have to go through that list by 4 different people when they had their visit, I think it would be helpful. And certainly if they end up paying twice for a CT scan because it wasn't available to the second provider, the original results, I would think that that would be beneficial for the patient.
Personally, I'd like to get to the point where I can have my swipe card and not get a clipboard every time I go somewhere to fill things in. Yep. Do you think we can get there? Absolutely.
And I see, you know, downloading your diabetic Accu-Check numbers right into the EMR, and so hopefully a lot of step savings for the patients in terms of what they have to go through to share information. That home monitoring that the woman in preterm labor is on at home, you know, being able to be fed right into the EMR and the provider being able to see that. You know, we're partway there, but there is a significant amount of progress that has to be taken to get to where we need to be.
Cool. So it sounds like really for this whole discussion is EMRs sound like a great tool, sound like we're going to add safety and quality benefits. Absolutely. We're maybe going to get efficiency benefits for the physicians at some point, but we will. Yeah, we hope we will get them in the back end of the systems. Overall, is there any silver bullet capacity for EMRs? Do you think they really are the savior of healthcare in America, as it's been kind of put into the media, or are we at a point where that's it's just the evolution of a new thing?
I see the EMR as a tool. You know, they are not going to replace providers. They're not going to replace some of the processes that go on, but I certainly hope that they will be a vehicle to helping us reform healthcare and being able to provide better care in a higher quality, higher safety, more efficient manner as we move forward.
Very good. Well, we've been here with Dr. Carrie Bunkers, and Dr. Bunkers, we'd like to thank you for coming on Health Connections tonight, and we will see you again next week. Again, this is Sean Riley from Health Connections. Thank you.
Thanks, Sean.
Thanks.